Hey, Creek kids. I want to introduce Kelsey. Kelsey is the very first of my students that went through the class and it now comes back to speak. So, Kelsey, thank you so much for being this really weird way of presenting. Have fun.
Oh, my pleasure. Thank you for having me. So my name is Kelsey Boyette. I'm a nurse at the University of Colorado Hospital off 225 in Colfax. I've been a nurse there for, this year will be 6 years, so it's gone by really, really fast. I have a little bio for you. So I apologize that my slides are grayed out. The formatting was weird, but I was a pre-med student in the fall of 2008 at Chaparral High School, the very first pre-med class with Mr. Stirrup. And that's what kind of started my whole career for the medical field. I wasn't 100% sure what I wanted to do when I was in high school, but when I started high school, I was pretty sure I wanted to either train Shamu or be a marine biologist. Turns out that killer whale trainers don't make a ton of money, and that's not exactly a realistic career path. So about my junior year of high school, I decided that I thought I wanted to go into the medical field, but wasn't exactly sure what part of the medical field I wanted to go into. And we'll talk about the things that kind of drove my decision to the nursing career. I was always interested because it's extremely versatile. You can do lots of different things in that field, and it doesn't exactly tie you down to one area of medicine. So that piqued my interest. And then through the pre-med class, there were presentations from doctors in all areas of the field. There were presentations in nutrition, respiratory, and then nursing really, really struck my fancy. So I graduated high school in May 2009 and decided, before I even graduated, that I was going to go to school to be a nurse. I originally went to Greeley for a year and then came home and ended up going to CU's nursing program, where I graduated with my bachelor's degree of nursing in May of 2014. I was already working as a CNA at the University of Colorado Hospital on the postoperative surgical unit as a CNA. They have a really great program that lets you start as a CNA and kind of transitions you very quickly into the new graduate nursing program. So I started as a CNA on the surgery floor. That just happened to be where I started and got my first job, and I've stayed there ever since because I absolutely love surgery, and I never would have picked that for myself. So I like to think that it happened by chance. It was meant to be. It was kind of fate. So I started in the new graduate nursing program in the summer of 2014, right after I graduated. And then about a year and a half, almost 2 years later, I got promoted to a charge nurse, which is currently what I do now. And I love it. It gives me a little bit of leadership opportunity without having to be a manager or work 5 days a week. So I still just do 312s, but I'm the charge nurse of a 36-bed post-operative floor. I got my CNA license in between my prereqs for nursing school and actually starting nursing school, and started working in the medical field right away. I think if you're not sure what you want to be, the CNA or the EMT route is a great option because it's a quick certification. It's like my CNA class was like 6 weeks, and then I could start in the medical field right away. And I think if you don't love either one of those, then going up the ladder to do more things, it will be obvious that that's not for you. But I loved being a CNA and knew that I only wanted to continue to learn more and do more. We also did cadaver labs at ACC when I was a pre-med student at Chaparral. And initially I was like, this is going to be gross. I'm going to be freaked out. But it was amazing, which sounds kind of weird. But it was like I'd finally be able to see some of the things that we talked about in our classes, like on a real human, and put all the pieces together. When I took my anatomy and physiology 2 class at ACC, I actually went back and took the prosection class as well. And it just like put all the pieces together, right? It was way different than talking about slides on a screen or just talking about things out of a textbook. You could actually see what was happening inside the human body or what had happened. So even though it's weird, it was a really great opportunity and even furthered my learning. So here's a couple pictures of me. This is me in my senior year of high school. In the bottom picture, I'm on the bottom right. And then the picture at the top, there's actually a human brain under the sheet in there. So if Mr. Stirrup feels obligated, there's a video of me after the cadaver lab just basically freaking out about how excited I was. So applying to nursing school is kind of a 2-step application process. So I had to apply to go to CU. I had to apply to go to UNC and get into just the college itself. And then after that, you have to apply to nursing school. So when I was in school, it was just they took the top X amount of spots they had based on GPA, and that's who got into the nursing program. But now they've kind of changed it. So it could be that you have the highest GPA, but they also perform interviews. So I think they were finding that there are some really, really smart people that maybe don't have the bedside manner for nursing. And so they're trying to weed out like who has the personality to be a bedside nurse, who has the, the GPA. And then they're also looking at other qualifications. There's some nursing schools in the area that actually want you to either have been an EMT or a CNA first, so you can get your foot in the door of the medical field to make sure that you truly like it before you go on to be a nurse. And then while you're in nursing school, there's 3 different types of classes that you take, right? There's the typical lecture that you take, the didactic portion. This includes the lectures, the tests, the projects, the research papers, everything that you think college is about. It's included in nursing school too. But then they take the stuff that they lecture you and they make you go to simulation. So CU has this really cool mannequin that can do basically everything. And they have you practice on the mannequin first and run through scenarios as a team, as yourself, practice skills like how to do trach suctioning or change a dressing. So that way, the first time you do it, it's not performed on a patient. And then you can practice with the equipment, and then you go to clinicals after that. So that's at a hospital, hospice, a nursing home. In the public health field, nurses are just about everywhere. So I feel like nursing school does a really great job of giving you the opportunity to experience all those areas so you can figure out what you like. I actually thought I would be an ER nurse forever and ever, and I'm not saying I never will, but I just started on a different area of nursing and actually really liked it. I'm not gonna lie, nursing school was hard. It was a lot of studying and a lot of time and effort spent into it, so it's not something you can just whiz through. I was working full time. I had a 3-year-old while I was in school, so it was hard, but it was definitely worth it. And I feel like the clinicals and the simulation really helped you understand what they were talking about when they were lecturing or going to the classes and stuff like that. These are some pictures of me in the simulation experience. So the top left photo is me wearing a BiPAP machine. It's a type of breathing machine we put on patients when they're having trouble getting air. They let us try it out so we would understand how people were feeling. And then here's just my simulation class all wearing BiPAPs. I think we look like Bane from the Batman movies. So nursing school is a little different too. You have to get a 75% or higher to pass in your classes. So anything less than a 75%, which would normally be a C in all of your other courses, is now an F. And I feel like initially I was like, wow, that's extreme. But looking back, I'm like, well, if you don't understand what they're talking about and you can't apply it, then you have no business taking care of people whose lives are in your hands. So it actually wasn't that hard, because if you're passionate about it, it's easy to study and it's easy to want to do well. And then there was pass-fail exams. So these were things in the simulation environment that we had to do. So you had to perform a dressing change, and you either did it correctly or you didn't. So you either passed or failed. And they gave you a couple opportunities to do that. Clinical attendance was mandatory. They gave you a schedule. They said, this is when you're showing up. There was a little bit of wiggle room, obviously, if you have big life choices, but essentially for 2 years, you kind of hand your life over to nursing school. Job opportunities while in school, I talked about that a little bit. I was a CNA at the university hospital I work at now, and they work with you because they know you're in school full time. It's a program specifically for nursing students, and I know initially when I did this, it was kind of just university had this program, but it's kind of spread to all hospitals in the Denver metro area, that they have this program for nursing students to start working as a CNA and get their foot in the door before they graduate. After you graduate with your bachelor's or your associate's degree in nursing, you can go on to get your master's degree. You can go on to get your doctorate. You can become a nurse practitioner with either of those. You can go into research. And then there's also a physician assistant program that's kind of separate from nursing. If you go through the doctorate route, you become a nurse practitioner. You can have a doctorate as a nurse practitioner. And the physician assistant is a separate 3-year program. You don't have to have a bachelor's in nursing to go that route. But you do to go into the nurse practitioner route, but they're essentially very similar if you get the doctorate. So you can't see my title. It says, why is it worth it? I think any nurse you ask will say that it's very rewarding, very humbling. I love it because while I was working and going to school, I worked in a cubicle and I hated sitting in the cube all day working on a computer staring at spreadsheets. So I love that I'm on my feet, I'm talking to people, I'm interacting with people, I'm extremely extroverted, and I could never go back to sitting in a cube full time. I think the only reason I was able to do it was because I could see the light at the end of the tunnel. But more than just what type of work it is, it's really fulfilling and rewarding. Um, I can have a direct correlation on someone's day, someone's outcomes, how their health timeline progresses, all in a 12-hour shift. My schedule is flexible. I have 2 young kids and a husband who's finishing a degree as well. So being able to work different shifts, work night or weekends, that has been really great for me. You don't have to work a flexible schedule like that. You can work a Monday through Friday job. But the great part is that there's tons of areas of nursing with tons of different schedule opportunities to fit your life however you need to. The other thing is I'm always learning. I'm always going to classes. I'm always taking new courses. I'm going to conferences and seeing what other hospitals are doing. It's a never-ending stream of learning. So even though I graduated, I feel like the person I was when I graduated, the nurse I was when I graduated, that's not who I am now because I've just learned so much in the last 6 years that I look back and I'm like, I don't even know who that nurse was, you know? And then, like I said, there's just opportunities in all areas of nursing. So why nursing? Why me? So the picture on the left is me and my dad. He was a Colorado Springs firefighter my entire life. He just retired last year, actually. He was a paramedic for a long time, and before I picked nursing when I was 16, a junior in high school, I went on some ride-alongs with him, and I just loved the like high-paced like continual medical stuff that he was doing. The paramedic part was definitely the part that interested me the most. During one of my ride-alongs, we went to a football game of a kid who had dislocated his shoulder, and they helped me watch them reset it. We got to take a bunch of people to the emergency room. We went to a fire, and the chief pulled me out and let me sit in the command and help run the radio. So it was just like something that I was like, you know what, I think this is what I want to do. And that's when I kind of started leaning towards nursing and the ER specifically. And then the next picture of the young gentleman in the hospital bed, that's my stepbrother. Oops, sorry, I hit the slide. And he, when I was in my freshman year of high school, my freshman year of college, so he got in a really bad motorcycle accident. He and his buddy were actually thrown off the motorcycle. It flipped after they hit a deer and it landed on his spine, and he is now a paraplegic. So while I was in school, he had all kinds of stuff happening to him, and I was able to help care for him. And I realized that I wanted to be the person caring for people when they were at their most vulnerable moment. And that's why I just knew that nursing was the route for me, because even though there were tons of people that helped care for him, it was the nurse who was at the bedside 24/7 with him through the whole recovery process. And then the next 2 photos, the one with all the people and then the one at the bottom, is me on a mission trip in Uganda. So this was after I'd been a nurse for about 2 years. We went over and just most of the stuff we did was like just educating them on basic medical needs. They had pills and they had no idea what they were for. And then a lot of them didn't have shoes and had lots of the calf down. They had lots of wound care. So the bottom picture is me actually doing wound care on a young woman's feet. And then also just educating them on how to care for themselves. So I love that, and I would love to continue to do more mission trips like that. This is just a funny meme of like what everyone thinks nurses do. And it is fast paced and it is busy, and some days it's exhausting. But like I said, I there's never a day when I'm like, this isn't worth it. Every day I come home, I'm like, well, I'm exhausted, but it was worth it. So the world of nursing, there's every area in the world that you could go into. You can go into the emergency room. Med surg is what I do. So specifically the surge, which is medical surgical nursing. So we take care of a lot of post-operative patients, but there's just medical patients that need help, people with heart failure, COPD, all the people that have coronavirus, all the people that get the flu, they all have all their medical issues as well that they need care in the hospital for. There's the ICU, the critical care areas, and there's tons of different areas for them as well. There's a specific surgical ICU, there's a cardiac ICU, there's neuro ICU, you know, every ICU kind of has its own specialty as well as every med-surg floor. Med-surg and ICU can be cardiac, pulmonary, there's obstetrics, so L&D delivering babies, kids is pediatrics, mental health, which is, you know, a need in every area of nursing. So you could work on a mental health unit or you could work in just nursing, but their mental health follows them everywhere they go. And then there's public health, so taking care of people out in the world today. You know, just because they're not in the hospital anymore doesn't mean that they don't continually need care in their health timeline. So I work in surgical nursing. So these are patients that are specifically post-operative patients. Usually these patients had a planned surgery. So they had cancer and they had a plan to get it removed, or, you know, they have Crohn's disease and they had planned to get part of their intestine removed, something like that. But it could be emergency surgery. So patients that have a perfed bowel, you know, you can't wait, you can't let that leak into the abdomen. We take care of all the trauma patients that come into the hospital. So anybody who's been in a car accident, was shot or stabbed, or fell down a flight of stairs, you know, those aren't planned things, but sometimes those patients still need surgery. And even if they don't end up needing surgery, if they have broken ribs that doesn't, you know, end up leading them to the OR, we still take care of those patients. Occasionally we get pre-op complications. So those are the people that came in and their appendix ruptured or something, and then we're just waiting for them to go to the OR. So they come to my floor too, and then we send them to the OR, and then we get them back after they're done. And then we get patients that go home after surgery, and then they end up coming back in with some complication, and then they come back to us as well. We get surgeries from all across the body. So there's different types of surgical units. There's a specific orthopedic unit that does like joints and stuff like that, and that's not the type of surgery I work in. There's also patients, like gynecological patients, those go to a specific area of the hospital. So most of what I take care of is like from the diaphragm or the middle of the chest down to the hip. Lots of bowel surgeries, stomach surgeries, stuff like that. So gastric bypass is one big one we do. It's for weight loss. We get removals of the appendix, the gallbladder, part of the intestine. A Whipple is a surgery that we do, and actually UC Health is kind of world renowned for this, and it's to remove part of the pancreas for cancer. And those patients don't tend to have a great surgical outcome, or a great like long-term prognosis once it's been diagnosed. So the Whipple actually gives them, it might not cure them, but it would give them more time. A sugar baker or a HIPEC surgery. So this is patients that have metastatic cancer all through their abdomen, and what they do is they go in and they remove as much as they can, and then they actually distill heated chemotherapy into the abdomen, and then they like shake the patient very gently, obviously, but on the OR table so that the chemo gets distilled all through there to help kill those cancer cells. A cystectomy, so this is part of the removal of the bladder. So any part of the urology system, we get that too. So kidneys, ureters, the bladder, anything in there, all the urology stuff comes to my unit. A lot of what we do is to treat and remove cancer, and a lot of what we do is trauma surgery related. So that could be any type of bone break, any type of repair in the chest or the abdomen from, like I said, a gunshot wound or a fall or anything like that. So this is what a gastric bypass surgery looks like. There's 3 types. A gastric band is the first one. They just put a band around the opening of the stomach so not as much food can pass through at a time. A Roux-en-Y is where the second one, they create a little egg-like pouch, but they leave the rest of the stomach in the body. And this also helps with weight loss. You know, they aren't going to be able to eat as much because their stomach is so much smaller. And then we get a sleeve gastrectomy. So they kind of cut a banana type stomach, and then the part that's grayed out, they actually remove that from the body. So that's not a reversible surgery. All 3 of these are for weight loss patients, and it actually works really well. And the best part is that a lot of these patients are diabetic, have high blood pressure, wear CPAP at night because they can't breathe. And once they lose the weight with this surgery, almost all of that is reversed. So they'll no longer be diabetic. They'll no longer have to take blood pressure medication. They'll no longer need CPAP. It cures way more than just their weight problem. A Whipple. So this is the patient that gets surgery for pancreatic cancer. And you can see, so the first picture, is what it looks like before surgery. And that's how the pancreas connects to the small intestine and the stomach and the gallbladder. And anything that's grayed out in that picture gets removed and it all gets sewn back together. It may not look like a lot, but that surgery is actually really, really complex because all of those areas of the body, they leak a lot of fluid. The pancreas is super sensitive. The surgeon that does this surgery at our hospital describes it as like sewing through butter that's been sitting out on the counter. And so that pancreas can leak enzymes, and the enzymes break down food in the body. And if enzymes are leaking into your abdominal cavity, it's breaking down anything in its path, which can include like large vessels and stuff because your body has vasculature everywhere. So these patients usually are in the hospital for 2 to 3 weeks. And because they take out part of the stomach, they don't feel like eating. They get really nauseous when they eat, and it takes them 6 to 8 weeks to really feel like themselves again. These patients also end up getting readmitted a lot because all those areas of the body leak fluid. They can get an abscess, which is a pocket of fluid in the abdominal cavity that gets infected. They come back in and they have fevers, chills, they have high white blood cell count, and they end up needing an interventional radiologist to go and put a drain in that pocket of fluid and drain it while we give them IV antibiotics. They come back in for all kinds of complications. So it's a really big undertaking. We do cystectomies. So this is removal of the bladder. There's 3 different types of surgeries that they can do with this. So what they can do in the first photo is just take out all of the bladder. Then they use part of the intestines or the bowel, and they make a little stoma that comes from the ureters to the outside of the patient's stomach. And then they get a bag put on there, and urine actually goes into the bag. It's called an ileal conduit or urostomy, and they have to drain that for the rest of their lives. The second one is a similar process, except the baseball looking piece in the middle is actually a new bladder that they make. And then that stoma that comes out to the outside of the abdomen, they can put a catheter in there and just drain it intermittently. It doesn't leak as often, and it's a lot easier, more comfortable. And then all they have on the outside of the body is actually just like a small hole. You can't see that entire stoma. It's just a very small hole that a catheter fits in, and they usually have to do that every 4 to 6 hours. The third picture, the body still looks the same on the outside. There's nothing brought to the surface of the abdomen, but the bladder itself is made out of intestine. So they take out the old bladder, take a part of the intestines, clean it really, really well, obviously, and make a new bladder out of that. And then the patient just urinates as they normally would have. Those patients all go home with a catheter in place. The third picture, they have to go home with one in their urethra for about 6 weeks, and they have to flush that new bladder pretty religiously because it creates a lot of mucus because it's going from being intestines to now being a bladder. So it has to be cleaned regularly. This is a nephrectomy, so part or all of the kidney gets removed, usually for cancer, but sometimes there's just tumors that grow on the kidney and then it obstructs the way the kidney filters the blood. So it also has to be removed. So this picture A is there's a tumor on the outside, they cut it out, and then they sew it back together. These patients usually spend a night or 2 in the hospital. They have to spend a couple nights because that new surgical site inside is at a high risk of bleeding. So we just monitor them for a while. We also get patients where they end up losing their entire kidney, and that one's usually for cancer. So they just take the whole thing out. They save what they can, but sometimes it's just not possible. A thyroidectomy, so this is where they remove part or all of the thyroid. Usually it's either for cancer or an autoimmune disease where their thyroid's just not working correctly. So if they take the whole thing, sometimes if the parathyroid can be saved, they actually implant it into the patient's forearm and it still works as a normal parathyroid would. These patients either go home right after surgery or sometimes they spend the night. If there's a lot of swelling or bleeding in the case, they'll want to keep them because, as you can see, the thyroid wraps right around their trachea. So if there's a lot of bleeding and swelling, it compresses their airway. So we usually just monitor them for 1 night and then they go home. The other thing is that the parathyroid also regulates your calcium levels. So we check their calcium pretty regularly because they can have symptoms of very low calcium in the body and we have to give them extra calcium. Bowel resection. So any part of the small bowel and the large bowel are fair game. Um, Colectomy is where they remove part or all of the colon. And usually this is either for ulcerative colitis, Crohn's, or again, colon cancer. And these patients can end up with feet of bowel removed, just depending on the type of disease that they have. These patients can either have it reattached, as you see here in this picture, and then their body will adapt and learn to work the same way it did before surgery. It takes a little bit, but your body will adapt. And if not, then they will put a colostomy on the outside of the abdomen. So another, again, a stoma with a bag, and that's, their stool will go into that. Sometimes for the rest of their life, sometimes temporarily, just for a few weeks, 3 to 6 usually, while the bowel inside heals, and then they can reverse it. Again, these patients stay usually until they have bowel function. Any type of anesthesia and manipulation of the bowel usually puts the bowel to sleep. So we wait till their bowel wakes up, because if it doesn't, they end up with really horrible abdominal distension, and then they throw up and they're really nauseated. So we want to make sure they're doing okay, and kind of return to normal before we send them home. Emergency trauma surgeries. So appendicitis, if the appendix bursts or is inflamed, we'll take it out. Same thing with the gallbladder, which is a cholecystectomy. Falls with injury, we see lots of people that fall and break ribs, and that's really painful. Usually there's no surgical intervention there, but those patients, because it hurts right along their chest cavity, it hurts to breathe. So we want to make sure that their pain is under control and that they're breathing okay on their own before we send them home, because if they're not breathing okay, they're going to develop pneumonia really fast, especially the little old people that fall. MVC is a motor vehicle collision. So we get all types of car accidents, and you can have anything broken from that. And I mean, those patients can be with us for any amount of time. It could be days, it could be weeks, it could be months that we've had patients that just need lots of help recovering and all the surgeries and stuff that they need. You also have to keep in mind that just because we fix a patient in the hospital, if they don't have insurance, there's nowhere for them to go. So they stay with us until they're able to go home and take care of themselves. Any type of trauma that has a positive FAST. So FAST is an ultrasound that they use in the emergency department when the patient comes in to see if there's any type of bleeding in the abdomen. If the spleen gets nicked, it bleeds quickly. If the liver gets nicked, it bleeds quickly. So they might have a laceration on either one of those organs that's bleeding, and it might not mean that they need surgery right now, but we want to watch them over time and make sure that they don't develop a bigger bleed and end up needing surgery later. If we get patients that come in for pre-op complications, these might be patients that have a known cancer and their pain is just out of control. So we'll admit them before their surgery. If they come in with an infection, we're going to treat them for the infection before we take them to the OR, because opening somebody with a known infection can be very risky. Any type of perforation, so if the bowel bursts from diverticulitis, or your urine is leaking into your abdomen, the inside of your stomach doesn't like it when any type of organ is leaking into your abdominal cavity, so it's very serious. We got to treat it right away. A bowel obstruction or an ileus. So if your stomach is filling up with fluid and food and it's not, you're not digesting and it's not moving through, that's called an ileus. And those people are really sick. They're just throwing up over and over again until your stomach and your intestines wake up. If you have a bowel obstruction, it can mean that there's actually like something obstructing the bowel. So it could be just air in there. It could be fluid. It could be that the bowel is actually twisted and it's not moving through. So depending on what's obstructing, it will determine how quickly you get taken to surgery, or if you get taken at all. If it's something that we can put a tube in your nose down into your stomach and relieve that nauseous pressure, and then your stomach kind of wakes up on its own, we won't operate. But if your bowel's actually twisted, if we don't go in and fix that, it can, the tissue can die, and then you risk losing more of your intestines, if not actually dying from that. Post-op complications, I mean, this can be anything really, but anytime you cut something apart and then sew it back together, right at that new incision line, you risk it coming apart, and that can cause a bleed. That can cause a perforation, or the bottom one here, an anastomotic leak, all of which are very serious. And then, like I said, there's vasculature all over your body. So you could have a regular surgery, but something in the arterial area or the venous got nicked and you could bleed out. Could be a fast bleed, a slow bleed, but we always watch for signs of bleeding. Most patients come out with some form of drain around their surgical site, and we monitor that drain for high output and then what color it is. It shouldn't be bright red blood ever. A pulmonary embolism, so a blood clot that goes to the lungs. You can actually have a blood clot anywhere in your body. It could be in your limbs, and usually that limb gets red, swollen, and inflamed. It could be a clot in your heart that could cause a heart attack. It could be a clot in your lung or a clot in your brain that causes a stroke. So we give all of our patients anticoagulation. So we thin their blood after surgery because you're at a higher risk of a blood clot anywhere in your body afterward. We also get them up and moving the day of surgery usually. If there's no indication for them to be on bed rest, we want them up and moving as soon as possible because that also decreases the rate of a blood clot. Sepsis. So this goes with infection, any type of infection. The drain sites can get infected, the incisions can get infected, inside you can develop that abscess like I talked about, that can get infected. And then we put catheters in your bladder and in your back for an epidural and down your nose. Anything that leads inside your body where it's not usually supposed to can cause an infection. So we're constantly monitoring their lab results for high white blood cells. We're looking at their heart rate and their oxygen and their blood pressure all the time. Just to make sure if they get an infection and we don't catch it right away, then they can develop a full body infection, which is what sepsis is. And that's a really big deal. So we got to, be diligent about watching for that. You can get a wound dehiscence, any type of incision. If it comes apart, that's called a dehisced wound. And that can happen internally at the surgical site or externally on like the outside of the abdomen. So we keep their wounds really clean. We clean them daily. And we always monitor those areas. A perforation, like I talked about, that can happen anywhere along the surgical site, or just if your stomach gets too full and we're not draining the fluid, it can actually perforate your bowel, not even where the surgery was. So all types of risks after surgery that we watch for. Hopefully none of them happen. Their course is very benign and they just go home. Nursing interventions. So nurses do it all, really. You manage all the tubes in their bodies. This is IV lines, epidurals. This is catheters in their bladder, catheters down their nose into their stomach. Any drain coming out of anywhere, that's the nurse's responsibility. In eyes and noses, intake and output. So you want to make sure that they're taking in an appropriate amount of fluid if they're able, as well as they have enough out of each area. If a drain's putting out a lot, that's a bad sign. If they're not urinating enough, that's a bad sign. So we're looking at that at least every 4 hours to make sure that everything is, where it's supposed to be. Same with their vital signs. We look at these at least every 4 hours. We look at their heart rate. Is it too high? Their blood pressure, is it too high or too low? We look at their oxygen percentage. Almost every patient we have comes out of the OR on some oxygen because they were on a ventilator for the surgery, and now we got to get them back to room air and breathing on their own. And then we look at how quickly they're breathing, their respiration rate, and then we also use pain as a vital sign. We expect patients after surgery to have some pain, right? We're never going to get it at a zero. We just cut into their body somewhere. But we want to make sure it's manageable, that they're able to breathe adequately. They can still get up and walk around, etc. Medications, any medication that a patient gets goes through the nurse. So the doctor orders it, the nurses give it. Aside from, the pain team that manages epidurals, I don't think I've ever had a physician or any type of other doctor give a medication for me. They just order it. It's a nurse's responsibility to make sure the patient gets it. Any types of dressing changes, this could be on wounds, this could be on, IV sites, this could be any type of dressing change, that's on the nurse too. Sometimes we get patients that have to do some packing into a wound, then we have to teach the patient how to do that at home, and that's on us. We also get patients that come in with wounds. Patients that get in car wrecks get lacerations anywhere on their body. That's our responsibility. It's our responsibility to make sure patients don't develop pressure ulcers by staying in the bed too long, but they could come from a nursing home where they already have a pressure ulcer, or maybe they're a paralyzed patient that has been laying in bed and they develop a pressure ulcer, and that's why they get admitted to the hospital. So those are our responsibility as well. We do all of the education. So patients go home on new medication. They have new drains that they've never seen before. Anything that is new to the patient, it's our job to make sure that we're educating them on how to take care of it. A lot of our patients go home with a nurse that will come see them at home as well, just to make sure they're doing okay, because we make so many changes while they're hospitalized. Charting, there's lots of charting. And it's always important to make sure that you're documenting everything that you're doing throughout the day. Obviously the day gets busy, but I try to stay on top of it throughout my shift, so I'm not charting everything all at once at the end of the day, because it's easy to forget in 12 hours all that you've done on multiple patients. Updating doctors. So the nurse is the first person who's at the bedside, the first person to look at vital signs, the first person to see lab results. So it's our job to let the doctors know if something's outside of normal limits, and keep them updated with what's going on with the patient throughout the day. Surgeons specifically, usually around first thing in the morning, see the patients at like 6 a.m. and then they're off to the OR for most of the day. Now, university is a teaching hospital, so there's residents and physician assistants and nurse practitioners that aren't always in the OR, but sometimes the whole surgical team is in the OR, so it's still our job to keep track of everything else going on with those patients until they get out of the OR in the afternoon, and then they round again. But really, they see each patient like twice a day for 5 minutes, whereas the nurse is at the bedside for 12 hours, 24/7. Nursing discretion. So initially when I graduated, I was like, I can't do anything without a doctor's order, and they know more than I do, but really it's a partnership, right? Like, they went to medical school and they have a ton of knowledge, but I'm also at the bedside taking care of them, going to classes, learning and stuff. So it's my discretion, and I'm advocating for the patient, and I know a lot too. And so it's my job to make sure that that position is updated, or that I'm doing what I also think is best for the patient. And if there's an order that they place, that doesn't necessarily mean that I have to carry it out if I don't think that that's what's in their best interest. It's always open for discussion, and we're really both there to do what's best for the patient at that time. So these are just some of the common tubes and drains that I see as a post-surgical nurse. The first one on the left is a biliary drain. So this could be coming from that abscess like I talked about. Oops, sorry. This could be coming from actually their biliary tract, so where bile drains from the liver. Sometimes patients get a leak there, and they need this to help drain their bile for them. But this is just kind of a basic drain that can drain kind of any type of area. Its friend up in the top right corner is a Jackson Pratt or a JP drain. This is like a little grenade, and it stays clamped like this to suction, and it, as it fills, it loses its suction, but it pulls fluid out of the body. And that type of drain is usually put at the surgical site to drain that fluid that we know will leak around the area that was operated on. And then once the drainage from that decreases in output, it gets taken out and it just pulls right out. The middle one there is a chest tube. So patients that have fluid that builds up in their lungs, or a patient that has a rib fracture that actually punctures the lung, this chest tube gets inserted to help reinflate the lung and drain all that fluid out. These can stay in anywhere from a day to weeks. It just depends on how quickly the patient heals. The picture on the bottom left is a wound vac. So patients with chronic wounds or incisions that don't heal, this is like a vacuum with black foam. And it actually gets attached to the patient and then attaches to this vacuum system, and it creates a pressure in there that actually promotes healing and creates new granulation tissue for that wound to heal. So if it's something that requires a wound vac, it probably wasn't going to heal very well on its own, and this kind of helps that along. The middle one there is a colostomy pouch. So part of the intestine was removed, and then this pouch was placed on the outside of the abdomen, and stool will drain into that. Like I said, sometimes it's a permanent thing that the patient has for the rest of their life, and sometimes it's reversible. It's just there to let the body heal for about 6 weeks, and then they can reverse it. The picture of the patient with the tube in their nose, it's a nasogastric tube. So this tube gets inserted in either side of the nose and goes all the way down into the patient's stomach. Sometimes this gets placed in the OR and the patient comes out with it, but a lot of times the patient's stomach gets so big that we have to place one to drain the stomach contents. And I feel bad. This is probably like the meanest thing I feel like I do to patients, because I just shove that right down. It hits that like gag reflex and then goes into their stomach. It doesn't feel good, but it's really important that I place it correctly, because if I place it incorrectly, it can actually go into their lungs, which I'll show you a picture of in just a second. And then that bottom right photo, that's a Foley catheter bag. So that's a catheter that goes in the urethra and into the patient's bladder to drain. And a lot of patients come out of surgery with that because the case was really long, they have an epidural and they can't pee by themselves, any type of thing, except we try to get those out as soon as possible because that's a high risk of infection and can cause a UTI very, very quickly. So this is a picture of that NG tube like I talked about. So the picture on the left is actually placed incorrectly, right? That tube is actually going into that patient's right lung. And unfortunately, it looks like in this photo that some type of fluid was put down that tube and is actually now sitting in the patient's right lung bed. So that's why it's so important that this tube gets placed correctly, which is how it's placed in the right photo. It's in the person's stomach, it's not in the person's lung, and it's gonna pull out stomach contents. So we always get an x-ray after we place these before we put anything down it or hook it up to suction, because we wanna make sure it's in the right spot. Usually the patient that gets it placed in the lung feels terrible. They might turn blue. Their pulse ox reading will drop pretty drastically, and I usually don't even need an x-ray to tell me it's in the wrong spot, and I just pull it out. Luckily, I've only done that one time, but it isn't uncommon. These are just a couple other pictures and x-rays. So the picture on the left is actually a picture of 2 stents inside a person. So it's a stent from the patient's kidneys all the way down into the bladder. So this person probably has either kidney issues or issues with the tube that drains from the kidney to the bladder, the ureter. So this is helping that drain. And sometimes when we operate in that area, we'll put these in so that it can heal, and then the stents get removed after the body heals, usually about 4 to 6 weeks after the surgery. And then the picture on the right is just a chest x-ray, but you can see the like heart outline there, and then on the bottom right you can actually see this like bubble, and that's not the lung, that's the stomach. It's a little bit distended, and that's where we would look to see if they have a really big distended stomach, then they need that tube put in their nose to help drain it. So sometimes we'll get an x-ray before we even place the tube just to see what's going on and why the person feels so bad. The other thing you can see in this picture, which is interesting, is there's a chest tube on the left lung, and you can see about the middle of the left lung there's a little, I don't know, it almost looks like a balloon, and then the tube comes out the person's chest wall on that left side. Patients that have chest tubes in, we get x-rays every day to make sure that tube's still in the right spot, re-inflating that lung. This is just some types of wounds that we see. So the first picture here is a really nice sternal incision that has staples in it, and it's healing beautifully. It's kind of orange just because of the dye that gets used to clean before the surgery. And then unfortunately, the patient directly next to that is a dehisced wound. So that wound did not heal, it came apart. That person either needs packing placed in there twice a day usually, or a wound vac, that like suction vacuum that we talked about. They can have little incision sites, those are lap sites, and then a bigger one, and that's so that the patient doesn't need a huge incision, they can just go in with little cameras. And then it's our job to make sure that we keep that nice and clean. Pressure ulcers. So it's also our job to make sure we're watching the person's skin. We check the patient's skin every shift, at least once, if not more frequently, because you can see that this wound on the bottom right, is it all healed up, but it got pretty deep. And if we don't take care of it, it can actually get worse. And the worst case scenario would be that it goes all the way into the bone. And if that happens, the patient's at risk of getting a bone infection, which can take years of antibiotics and surgeries to get rid of. So it's a big deal. It's important that we're keeping an eye on their skin throughout their entire hospital stay. So I have a couple case studies that I wanted to go over. I don't know if Mr. Stirp wants me to go over them, or if you want to go over them.
You are welcome to go over them, Kelsey.
You want me to?
It's up to you. I'll leave it if you want to do it, or I could also post this so they could look at it later.
I can go. I'll go over one, and then how about I let you guys go over the other ones?
Perfect.
Okay. So case study number 1. So this is a 24-year-old male patient 1 day out of surgery from a cystectomy. So he had his bladder removed yesterday. He's 24, but his past medical history includes lots of previous surgeries. He's developmentally delayed. He's had a pulmonary embolism, so a blood clot in his lung in the past, and he's limited mobility. He cannot get out of bed. His hands and feet are contracted, meaning he can't move them like normal. They're stuck like this. So you come on for the shift and you get report. The patient's tachycardic, so his heart rate's up into the 130s. A normal heart rate is anywhere from 60 to 100. And it was like that all of the shift. His pain medication got removed from his epidural because he's unable to communicate with us very well due to his developmental delay. The team thinks the patient's in pain, and that's why his heart rate is so high. So we're waiting on acute pain service, the people that manage the epidural, to change his pain medication, put some more back in his epidural line, and they're hoping that that will fix his tachycardia. At 11:30 at night, the RN calls that the patient's heart rate is in the 140s, so it's gone up from 130s to 140s. His oxygen requirements have gone up from 2 liters of oxygen to now requiring 6 liters of oxygen, and even on 6 liters of oxygen, he's only sitting at 86%. It's not uncommon for patients to be on 2 liters of oxygen after surgery, but even still, we want them to be above 90% at all times. So the intern arrives at the bedside after you call them. The intern is somebody who's in their first year of residency, so they're their first year out of medical school, and at a teaching hospital, that's the person who comes first when you call. And he says, let's draw some labs. So you draw them, they're sent. Previously, it showed a very small increase in his white blood cell count. So a marker for infection is the white blood cells, and then a lactate. Anything going on in the body that is anaerobic or aerobic activity. So anaerobic, you've run out of oxygen and you're not perfusing your cells very well, they will start to generate lactic acid. So we check a lactate to see how much lactic acid the body is making. So his lactate's 2.1. Anything around 2 or less is considered normal, and we usually don't intervene. 2 and above can be considered high, or we trend them, meaning we'll get another one later to see if it's continuing to go up or if it's coming back down. So you're the nurse at the bedside, and what do you do? I'll let you talk about it or think about it. So here's what I'm going to do. I'm the charge nurse, and here's what I'm going to do. I'm going to put the patient on a non-rebreather. So they had a nasal cannula in their nose. I'm going to get the full mask, and I'm going to increase them from 6 liters to 15. We have to get their oxygen up because they're not perfusing their cells if they're sitting at 86%. After a few hours, I'm going to get repeat labs. It shows that nothing's changed. His white count's still a little bit high, and he's still at 2.1 for lactate. Sometimes residents like to get an EKG just to make sure that there's nothing else going on with their heart rate when it's that high. But his EKG just shows sinus tachycardia, which means it's a normal rhythm, but it's fast, which we already knew. And his chest x-ray shows a right pleural effusion. So the right lung has fluid in the bottom of it. Kind of like what I showed you on the picture with the x-ray where the tube was in wrong. That fluid at the bottom can be considered a pleural effusion. I'm going to call a MET after this if they're not responsive. So this is a MET or a rapid response. It brings an ICU nurse to the bedside, the hospital manager to the bedside, as well as a respiratory therapist, because chances are I'm going to need a couple more hands than I have to deal with everything going on with this person. And maybe that ICU nurse or that respiratory therapist has ideas that I haven't thought of yet. If the intern's not sure what to do, I'm going to say, hey, have you called your upper level resident yet? Or I may say, if we're still not getting the answer I want, have you called your attending yet? We're a teaching hospital, but at the end of the day, it's up to me and the attending physician to decide what's best for that patient. So if the intern's not sure what to do, or even if they think they know what to do, I'm still like, you need to let someone who's more than a year out of med school know what's going on and make sure that they're involved as well. If they still don't come, I'm going to have them call the chief resident. So this patient's in their last year of or the chief resident is a person that's in their last year of residency. And if it's in the middle of the night, they're at home. But I don't care if this patient's not doing well and I'm not getting what I want. I need you to wake them up. And the same thing with the attending. They're probably not there either. But if if they're not, I need them woken up at home, because what's best for the patient trumps them getting some sleep. And then they're going to order a CT scan. So they chat about it. They decide, we're not sure what's going on with this person, but we're going to get a CAT scan. So what we know is that the patient has a little bit of increased white blood cells, not drastically. Their lactate's a little bit high, but they've required way more oxygen than before, and their heart rate is really, really fast. So before all of this happens, usually I can say, like, these are their vitals, this is what's going on with the patient, and this is what I think is wrong, and this is what I think we should do about it. So what are you thinking is wrong with the patient that we're looking at right now? I'm going to say, I think this patient has a pulmonary embolism. They have a blood clot in their lungs. It's not an infection because their white count's not that high, their lactate's not that high. Their right lung shows an effusion, but they've required way more oxygen, so something's not getting through, and their heart is working really hard to try to perfuse their body. So as the RN, I want a CT scan, but I want a CT scan specifically looking for a pulmonary embolism. And then what's best for this patient? If this patient is requiring this much monitoring, I want them in an ICU where someone can keep closer eyes on them, because they only have 2 patients and they're taking vital signs every hour, as opposed to them being on my floor where we have 4 to 5 patients at night and they're taking vital signs every 4 hours. That's not enough for this person. So the patient's transferred to the CAT scanner for their CTPE, and then they go to the ICU after that. The CT scan showed no pulmonary embolism, but it did show a deflated upper lobe of the lung, which wasn't seen on their x-ray. So instead, they get a chest tube placed at the bedside. I might be wrong as the nurse thinking that they had a pulmonary embolism, but I got the outcome I wanted regardless, right? No one could have predicted that this patient would have a deflated right upper lung, but it's still important that they get a scan to check for any abnormalities in this person's body, as well as get them into an ICU where someone can monitor them more closely. These are just a couple of pictures that I have of just my nursing career. So you might recognize Mr. Stirrup in the photo. This is the first time I ever presented to the Cherry Creek pre-med class. The left picture is me talking to new graduate nurses about 2 years into my nursing career, just of what my journey looked like and what their journey might look like. The first year of nursing is hard. It's not quite everything you imagined it would be. You're more tired than you expected, but it gets better. The top right photo is of me and he's a charge nurse now, his name's Tristan, and he was the first new graduate I precepted. So I'm about 2 years out of my new grad program, and I got to precept another new graduate nurse, and that was really fulfilling for me. I love teaching new people and sharing what I know, but they also ask really great questions, and it highlights maybe things that I don't know, and then we learn together. And then just the camaraderie on a shift. So that bottom right corner is a picture of all of us having a potluck on Thanksgiving a few years ago. And there is no friendship like a nursing friendship or a team like a nursing team. I mean, you rely on other people to help you all day long, each and every day. We also have a very specific sense of humor that I'm not sure other people in the world develop. And some of these people have become some of my best friends, but it's been a really great experience, and I wouldn't change any of it. So if you guys have any questions that you want to share with Mr. Stirrup, he can get them to me, and I would be happy to answer them. I've had a few people ask to shadow me at past presentations, so with the world of COVID right now, I don't think that's as much of a possibility. But if you are interested in shadowing a nurse or myself, most of the volunteer offices have a program at every hospital that you can go through and just see what it looks like. My last little story is that Dr. Pete Baker, who helped found this class, he was a GI doctor, and so he was letting students that first year go and watch either an endoscopy, so a tube that goes down the mouth into the stomach, or a tube that goes into the rectum and through the colon, so a colonoscopy. He was letting students go watch some of those procedures. I think I was signed up to go on like the 4th or 5th day, but the first 3 days, every single student that went passed out. And I was so upset because I really, really wanted to go, to the point where he finally made an exception for me. I think I was just mostly very annoying. Um, but I went, I got to see both types of procedures. It was really fascinating, as weird as that sounds. And I learned a lot, and he was so kind. He passed me off to a radiologist next, and I was in a dark room with CT scans and x-rays and PET scans and MRIs, and that radiologist spent time just showing me what he's looking at on these images. I still can't always read all of those images, but it's important that a nurse has a general idea of what's going on when a patient has any type of imaging done. I then later ended up in the ER at Skyridge with a nurse who just like walked me through what it meant to be a nurse, what her day looked like. And that whole shadow experience just solidified that I was absolutely meant to go into the medical field, that nursing was the route I wanted, and I wouldn't change any of those experiences for this career. I really, really love it.
I remember your words to Dr. Pete Baker when he had to cancel everyone, and you just kind of said words of paraphrasing was, "It's not my problem that there's too many weak-minded people in this class," or something on that line.
Yeah,
I thought it was hilarious.
Yeah,
I know that Pete loved and respected you for that, saying, "All right, you're coming in."
yeah, and I didn't pass out, and I've never passed out at work from anything medical related, so that's good.
Oh no, you told one time you had a little problem with the gangrene.
Oh yeah, there was some wound care one time, and it was about, I mean, I hadn't eaten in about 9 hours, and I got a little lightheaded and had to sit down, but I didn't fully pass out, but I was slightly embarrassed. I was still in nursing school, but I like to think that I have, you know, grown, and that wouldn't happen to me now.
You were in the class. I'm pretty sure you were in that class when Dr. David Oster was speaking. Were you in the class that 6 students passed out during his presentation when he's showing the hip
No,
replacement? That
I
might have
did
been
get to come in for the presentation you have of the doctor who responded to
Columbine.
yeah, that was really moving.
Yeah, Dr. Hunt. He actually is now retired, but he is the director of the EMT program at Arapahoe Community College now.
Oh, that's great.
Yeah, but he's retired as an ER doc, and I still have lots of nice communication with him, and but we're trying to get them lined up with the EMT so we can start mainstreaming kids, from the high schools here and Cherry Creek schools right into the EMT program. And so
That would be awesome.
I know, I'm like, and when I first met with them, and this was 6 years ago, they had said, would it be all right if we had an ambulance on campus? I'm like, of course. They wanted to have have the training ambulance. And the funny one about one of our flight nurses, she is in charge of, she's one of the higher ups with Flight for Life, or who's the green helicopter? The Flight for Life, or
Flight for Life's orange.
whoever the green one is. Green. I can't remember the green one. They fly over my house all the time, but she wanted to have one of the helicopters land here on campus during the class so the kids go check it out. And everyone thought it was the greatest idea until risk management for the district found out about it. And they put the big no. So like, we don't land helicopters on our campuses. I'm like, they're not amateurs. So
like, they're professionals.
Yeah. So all right,
I recently started doing I fill in as a hospital manager occasionally, like once a month if there's not a permanent one on. And in order to do that, I got to go up to the helipad and do training, and they did have one of the UC Health Flight for Life helicopters land. It was really interesting.
Huh.
Yeah.
That's awesome.